So good afternoon. My name is Tanuj Mahendru, and I just presented my abstract previously on Klippel-Feil syndrome. I will also be presenting my abstract on trauma management in a 20-year-old female with Mauriac disease. Once again, I would like to thank the Southern Medical Association for inviting me to speak on this topic, and my principal investigator, Dr. Robin Richmond, for allowing me to partake in this opportunity and present this to everyone today. So without further ado, this is my abstract on trauma management in a 20-year-old female with Mauriac disease. So first, I'd like to start with an introduction and discuss what Mauriac disease is and how it's diagnosed. Mauriac disease, also known as diabetic dwarfism, is a rare metabolic condition involving type 1 diabetes. It was first discovered by Pierre Mauriac, a French physician, in 1930. When type 1 diabetes is improperly managed in children, this can lead to permanent health consequences such as Mauriac disease. The exact pathophysiology and rate of occurrence is still unknown, which can likely be attributed to gaps in research and lack of case reporting. The diagnostic criteria for Mauriac disease only includes two items, one being poor control of type 1 diabetes, and the second being severe hepatomegaly. Metabolic dysfunction in these patients typically causes an increase in glycogen deposition in hepatocytes. Usually, the GLUT2 transporter in the liver is involved in moving glucose into hepatocytes independent of insulin. However, in patients suffering from Mauriac disease, glucose continues to be deposited in hepatocytes even during hyperglycemic episodes. As a result of this inappropriate glycemic control and transport dysfunction, there is abnormal liver enlargement, hypercholesterolemia, and elevated liver enzymes, all of which are evident in lab work. This also contributes to a significant increase in lactic acid levels in the blood, leading to persistent lactic acidosis. I have included a diagram displaying the physiology of increased glycogen deposition in hepatocytes, which can lead to glycogen hepatopathy and hepatomegaly. As you can see, due to that increased glycogen deposition, this is going to result in the enlarged liver. Now that we've had a basic introduction to the pathophysiology of Mauriac disease, let's review the clinical presentation for this patient. A 20-year-old female with a past medical history of type 1 diabetes mellitus was brought to the emergency department from a rural area after a motor vehicle accident. The patient's initial diagnosis of type 1 diabetes was 12 years ago, following a hospitalization for diabetic ketoacidosis. Medical management for this patient currently involves a routine of injected insulin, Lantus, and Novolog, and a Dexcom device to monitor her glucose levels. The patient has poorly managed her diabetes since the initial diagnosis in 2011, leading to several past hospitalizations for diabetic ketoacidosis till date. She presented with tenderness in the right shoulder and sternum and had a protuberant abdomen. The patient underwent an upper gastrointestinal series, which showed no visible contrast extravasation. However, her blood work revealed continuous elevation in lactate levels. It also revealed high aspartate aminotransferase, high alanine transaminase levels, and hypercholesterolemia. Physical exam of the abdomen was normal. There was no tenderness nor guarding upon palpation of the abdomen. She was determined to be hemodynamically stable. The CT read as extraluminal air not consistent with the exam, and a small bowel follow-through confirmed that it was a gastric diverticulum. Additionally, if you look at the CT abdomen of this patient on the slide, you will see that the length of the liver measured from this area to the inferior aspect is about 18 centimeters. The current guidelines for hepatomegaly state that the length must be greater than 15 to 16 centimeters. And so, given the patient's history of improperly managed type 1 diabetes and hepatomegaly as confirmed by the CT scan, allows clinicians to confirm that this patient is suffering from Mauriac disease. Now that we've had a chance to discuss the introduction and case presentation, let's review management and outcome. The patient was admitted to the surgical ICU for overnight observation, with monitoring of her lactate levels and frequent abdominal examinations. The purpose of the physical exam was to ensure that she remained hemodynamically stable throughout the night. She was also administered intravenous fluids and intravenous Zosyn. No surgical intervention was required in the treatment plan for this patient. She was given inpatient education on lifestyle management for type 1 diabetes and was discharged the following day. She was instructed to return to the emergency department if any sudden onset of PO intolerance, fever, or abdominal pain were to start. This case emphasizes how improper medical management of type 1 diabetes led to irreversible health consequences, such as the patient's stunted growth and developmental delays, along with frequent hospitalizations for diabetic ketoacidosis. Let's review what was previously discussed and conclude the case presentation with a discussion. The exact pathophysiology of Mauriac disease is still not known, hence why this rare condition is diagnosed by the criteria of having poorly controlled type 1 diabetes and severe hepatomegaly. The GLUT2 transporter in the liver normally shifts glucose into hepatocytes independent of insulin. However, in Mauriac disease, glucose continues to be deposited in hepatocytes even during periods of high blood sugar. As a result of this transport dysfunction, this can lead to abnormal liver enlargement as seen on the patient's CT scan. Also, the hypercholesterolemia, elevated liver enzymes, and persistent lactic acidosis also was evident in blood work. The minimal knowledge on this subject can be attributed to the lack of data and case reporting, leading to gaps in research. There's currently no form of treatment for this disease. However, the condition is simply managed by controlling the patient's type 1 diabetes. Rural areas with inadequate resources typically do not have access to preventative health care, leading to greater health disparities. This case study shows that as well. Furthermore, this case report illustrates the need to increase diabetes education in rural populations to avoid permanent health costs for patients. If type 1 diabetes is not managed in young patients, they can suffer irreversible consequences like Mauriac disease. By providing resources to these rural areas, this could result in a positive shift for health outcomes, reduce the occurrence of this rare condition, and change pediatric clinical diabetes management. Additionally, this case study illustrates how Mauriac disease, in conjunction with an acute episode of lactic acidosis and gastric diverticulum, all complicate trauma management. While diabetic ketoacidosis is a known complication, this case report is evidence of a patient having an increased length of stay and unique difficulties in treatment due to the combination of a motor vehicle accident trauma superimposed on Mauriac disease. Thank you.